All right, so welcome everyone to the July Behavioral Health Advisory Group meeting. Thank you so much for joining today. So to get us started today, we will start with some introductions, and then we have an exciting new co-chairs update, and there is an update to the Maryland Consortium after the meeting last week. We have some strategic planning to go over to continue from our discussion last meeting. We have a lot of community announcements, and then we will show you the next upcoming meeting dates, and then we will adjourn for the day. So to get us started, if folks wouldn't mind, you can either unmute or you can continue to add in the chat. But if you could introduce yourself with your name, organization, and we have a fun prompt of one daily or weekly thing that you do to maintain work-life balance. And I can go first. My name is Taylor Palmer. I am with the Prince George's County Health Department, supporting this the Behavioral Health Advisory Group. And one thing I do to maintain work-life balance is I'm not doing it right now, but I try to have an office separate of my living quarters. So keep the two separate. Who would like to go next?
I'll go next. My name is Margaret Fowler, and I'm the Executive Director at Totally Linking Care in Maryland. And the one thing I do to keep work-life balance is I walk my dog at least twice a day, or she walks me, I should say, but she keeps me humble.
Margaret, you stole mine. I was going to say I walk my dog over lunch on the days that I'm home, and it really is a helpful reset. I'm Nina Ward. I recently joined the Prince George's County Health Department as Public Health Program Chief with Behavioral Health Services. So good afternoon, everyone.
Good afternoon, everyone. Denise Dunbar here, Public Health Program Chief with the Behavioral Health Services Division in the Health Department. And I do gardening. I'm actually reaping some really nice tomatoes and some jalapeno peppers right now. So I'm excited about that.
Mm-hmm.
Hi, everyone. I'm Dr. Wiggum. I'm with the Health Department. The one thing that I do daily is I try so hard to end my day at 5 o'clock to just do an 8-hour day. So.
Good afternoon. I'm Kimberly Atkinson. I'm Assistant Regional Director with the Department of Juvenile Services in Prince George's County, also Region 7, which is Calvert, Charles, and St. Mary's. And my weekly thing that I do is I probably read a book a week and walk my dog.
Hello, everyone. I'm Carlos Mackel. I'm the Strategy Manager and Project Manager of Behavioral Health for Totally Linking Care. And things I do is like to work out, ride my bike, and yard work.
Hello, my name is Jordan, and I work at Affiliated Sante Group, and I manage the day program, and I just spend as much time outside as I possibly can.
Hi, everyone. I'm Courtney Reed. I'm having a bit of computer issues in terms of my camera, but one thing that I do daily is have dance parties with my 3-year-old and 9-month-old.
Good afternoon, everyone. I'm Mike Williams, the Director of Returning Citizens Affairs Division for Prince George's County. And the one thing that I'm doing every day now is walking 2 miles each morning before I get started working.
Hi, everyone. I am Kim Stinchcomb. I'm the manager of the Healthcare Action Coalition with Prince George's Health Department. And every day, if I need a little break, I just try to do some watering or pruning in my garden to have a quick refresher.
I'm getting a lot of ideas for what to do after work today. All right, so continue for folks who do not wish to come off mute, go ahead and continue putting those in the chat, but otherwise we will move to our next agenda item, which is very, very exciting. So it is my pleasure to introduce to you our new co-chairs of the Behavioral Health Advisory Group. So a huge round of applause to these individuals who have expressed interest in co-chairing this group. So first, we have Margaret Fowler. She is the Executive Director of Totally Linking Care in Maryland, TLC MD. Margaret is an experienced, innovative leader and visionary who creates effective, collaborative solutions for improved outcomes. With over 25 years of experience working in the hospital and healthcare industry, she is skilled in nonprofit organizations, team building, fundraising, innovative solutions, healthcare management, operations, and worksite wellness, care coordination, and navigation. So welcome, Margaret.
Thank you.
Next, we have Nina Ward. Nina Ward serves as the Public Health Program Chief with the Prince George's County Health Department Behavioral Health Services Division. She is responsible for a portfolio of programs that provide community members with connections, referrals, support, and information regarding behavioral health and other social determinants of health-related services. Nina joins Prince George's County from the National Association of Counties, NACO, where she led the Familiar Faces Initiative and other national projects aimed at improving local behavioral health systems, including crisis response continuums, and reducing recidivism. Prior to NACO, Nina worked at the Maryland National Capital Park and Planning Commission and the National Academics of Science, Engineering, and Medicine. Nina holds a bachelor's degree in anthropology from Elon University and a master's degree in public policy from the University of Maryland. Welcome, Nina. And last, to support the group as well, we have Carlos Mackel. And so if Margaret is ever unable to volunteer, Carlos will graciously step in. So Carlos leads TLC MD's behavioral health program. With over 15 years of experience, Carlos has extensive experience helping individuals experiencing mental health and/or substance use disorder challenges. Carlos was instrumental in the creation of the 988 workbook that supports all 50 states with the rollout and delivery of mental health and substance use disorder services. He has held senior and executive leadership positions with oversight of crisis response programs that have included crisis stabilization services for inpatient, subacute, residential, and outpatient. Welcome, Carlos. All right. And for our folks here, would you guys like to say anything to the group beyond your very, very extensive introductions, all very well acclaimed?
I would just like to say, I appreciate this opportunity to be able to work with this group. And, I look forward to what we can build for the behavioral health services in Prince George's County.
Likewise, thrilled to be here and to collaborate with all of the partners that are in this room and throughout the community, and excited to be part of it.
Wonderful. Certainly looking forward to the next steps. And with that, we have an update on the Maryland Consortium on Coordinated Community Supports update. So I know this has been much anticipated, that RFP. There was a meeting last Wednesday, July 12th, where the consortium did release that the RFP has not been released yet. They did share that. And the best way to stay connected at this point to know when the RFP will be released to the general public will be to join through that email list. So again, if you aren't already on that, I would highly suggest adding yourself to that. So we will send out all of the slides and notes after this meeting, but here is a link to the meeting recording from last Wednesday where you can review all of the updates that they did share about the RFP. But again, the most guidance that we have received is to stay put, that it is coming later this summer. So again, try to stay connected as best possible with that email list. There were a few updates that were offered during the meeting to the RFP. So the first update being that hubs will most likely not be funded in the first RFP, and that majority of the focus for the first RFP will be on these tier 1 interventions. So the consortium is collecting feedback from the public. If you are able to offer any of your feedback, public comments are being are open right now to be collected. So if you click on this link, they will be due this Friday. And there's a smart sheet here that it will take you to, so you can give your comments about all of these recommendations that are coming from the NDH, as well as view the recording if you were unable to make that meeting. Are there any general reactions if folks were able to attend the meeting, or anything anyone would like to discuss regarding this opportunity?
Yes, Kimberly, this is Larry App from Shepherd Pratt. I actually serve on the consortium, and I just wanted to say that if people have issues with the restriction of the funding to tier 1, which means just prevention services and not treatment services, that they really should weigh in, because it's a very critical issue, because I know there is a desperate need for funding for treatment services. And if your agencies feel that you have a need for treatment services, funding for treatment services, then it's so important, to weigh in on that.
And so again, public comment will be available until close of business this Friday. So we will make sure to get out the notes and the slides as soon as possible for you to be able to visit that link and provide any feedback you may have.
This is just a random thought that I'm having. Is there any interest in us pulling together, obviously in 2 days, a response from the voice of the coalition, or would we prefer to keep kind of those responses just numerous and spread throughout all the individual partners?
Kim, I'd like that idea. I think sometimes if we can collectively go in as a unified force with maybe different people, the different organizations who support those comments, I think that might be a really great idea.
Okay, and I know given the, the responses are due by Friday, maybe I can follow up and we can see if there's something we can just send out to get, immediate feedback from everyone, or we can draft something and see if we have enough support to push that out.
Okay.
All right, so identified next step, following up on this opportunity for feedback. We will be in contact regarding pulling together some comments for this opportunity due on Friday. All right, and with all of that being said, we are now going to move into the strategic planning following up from last month's meeting. So under each of the slides, we have our goals and objectives, and we will need to work through some next steps to achieve those, as well as get some feedback on the goals and objectives. So again, just so folks do remember just to put this on your radar, the proposed timeline for the strategic planning will include having a draft of the work plan by our August meeting and then being able to present all of the information that we put together at the September PGHAC meeting, the quarterly meeting, which will be virtual in September. So that is what we are working towards. So for each of these, so there are 2 proposed goals, taking what the group had identified during the last meeting. So please do feel free to come off of mute or put it in the chat. Any reactions you have to goal 1 or any of the objectives or strategies. And so goal 1 is primarily relating to the integration of behavioral health services across the county, regardless of zip code, to be able to get folks from different arenas to come together and create this continuum of care dashboard or map, something that gets all the resources together and something that an individual could use to figure out where to access help, as well as providers where they may need to refer someone in the county.
If I can just add a little bit, I wanted to also just add that, we know there's a lot of services that are currently existing in the county, but sometimes they may be in silos or people may not be able to or not aware of them, or services within each of these individual programs may have a beginning and an end. And then we want to make sure that we navigate them from, they need additional services from one program ending, not leaving them just sort of, where do I go now if they need these extra services, and building this continuum where they have lower and lower intervention levels. But, sometimes if you have a high intervention on a daily basis and then it's stopped suddenly, you want to make sure that we have provide that support along that whole continuum. So that was sort of the thought behind this. I don't know if anybody had any thoughts or input that they'd like to add or think could be, added, deleted, or other suggestions. So is this good with everyone? So we're going to take that as it's okay to proceed with this goal and objective and strategies. We want to make sure that everybody's included, in this, that we want everybody to be a part of it, and help us to build the strongest continuum we can.
And with that, I'm curious if folks have any steps that they think are necessary. I know, Margaret, we've talked about a few next steps to work towards these strategies. What needs to happen? What does this group need to bring together, whether it be resources or thoughts or ideas? Does anyone have any ideas about steps to take to achieve these 2 strategies?
My first thoughts are, and this came up for our second goal too, which we'll get to, but that a lot of us in program areas and our partner entities are mapping out services in specific areas. And so I think it would be helpful if we collate all of these maybe niche area or subject matter area specific mapping exercises that we may have completed individually and bring those together as a starting point for what we're hoping to put together, as Margaret was saying, is a more global view of a behavioral health continuum. So I'm not voluntelling anyone, but if you have already started this type of process, I think it would be really helpful to bring all of those together.
Yeah, and I think we're also looking at some things like we talked about chronic disease management because we're on that side of the fence. Actually, we're developing similar mapping, geo-mapping of food pantries, geo-mapping of DPPs. So, we have the knowledge base from a county perspective. So again, just adding these additional resources and really, again, we are calling it a behavioral health continuum of care, but truly it is just a continuum of care because behavioral health and medical health or chronic diseases, it's about the whole person. But, for where we are now, just for delineation, we should be building this continuum of care for the whole person, which would include both medical and behavioral health services. So, we do have experience with doing some of these on the medical side. So it's just really, again, bringing together the whole person, both the behavioral health as well as the medical health of a person.
One other thing I think we talked about was that definition of different categories or levels for each of the care to kind of start as that overarching, where do the services lie within the continuum? So how do we categorize each of those steps?
Mm-hmm. Does anybody have anything else they'd like to add, and should we go to the next slide? And please, if you don't feel like commenting, you can always put something in the chat, or you can email Kim later as well.
Everyone's quiet today. Is it midsummer or something?
How's everybody? Hear me? You guys hear me?
I think we can barely hear you.
I'll try to speak up. I was thinking for that first. Oh, I'm sorry. I'm Dr. Gregory Bearstuff. I'm Chief of Inmate Service here in the Prince George's County Corrections. So, and I was thinking about looking at the first integration of a behavioral health.
We're still having a little bit of a problem hearing you.
Hear me now? Is that better?
Oh, that's better. Yeah.
Is it possible to talk a little closer to your microphone?
How's that?
Yeah, much better. It's
much better.
Yes.
Okay, I'll do that. So I was looking at the promotion of the integration of behavioral health somatic services among our providers and community programs for, and I don't know if this has been brought up before, but I know that we've been working here, Department of Corrections, and also a little bit with the health department, but with, I don't know if you're in the Pocket app. So we, people or detainees that are leaving and going back into the community, they have we work with them to install the Pocket app on their phone, and that allows them to keep in contact with case managers here, some of the reentry case managers, and we're able to refer people, detainees, and citizens that are coming out of at least the jail, that we refer to the Adams House, but also to other providers through the app. And I think that the app has been a really important part to continuity of care among uh, the reentry resources, Adams House. I know there's a medical clinic one floor down. Dr. Wiggum, who's on, has knows about that as well. And so I just would throw that out there as another means of integrating the two among, again, our providers programs, because the features in the Pocket app are, and I don't know how many of you are aware of it, but we are using it, and people, detainees, at least citizens, are leaving with it on their phone. But what better way to keep in touch with everyone but through an app on the phone, and where we can also refer to providers, our partnering providers in the community, as well as send messages to be able to communicate among all the partners, among all the providers, and it's practical because everyone has a phone, and everyone has it readily accessible. So you can receive messages. You can communicate via text about care, appointments, medication. So I think, at least I'll throw that out there. I think it's a wonderful way to integrate all of these services, uh, especially for some of the most people that really need the continuity of care and a range of services. So let's throw that out there.
No, that is absolutely wonderful. Now, is it Pocket, like POCKET app, or is it a?
No, it's a POKKET. POKKET, right? And the Pocket app. And we're actually I don't know how many on the call know that within the jail here, all of our detainees have tablets. So one of the things we want to do here, working with our tablet vendor, Securus, is to install the Pocket app on the tablets. So again, if when that happens, then even though people are in jail, you still can connect with them and do case management through their tablets. So we've got a lot of opportunities for innovation and bringing innovation, but also continuity of care services, which begins when people actually get booked into the jail. But at some point, we hope most people are going to be returning to the community, and that's one of the reasons why they need all of our services on the call, because we're trying to, external goal for us is to reduce recidivism. People coming back, they're returning detainees for similar crimes or similar reasons, because of their addiction or mental health. So what better way to maintain that technologically? And then internally for us, through our programmings, we want to be able to bring down incidents in the jail. So again, with our internal programs.
No, that sounds absolutely wonderful. Would you like to demo it for us? I would love to see a little bit more about this, or maybe we can bring it to the group. And I think what would be nice is what kind of data can we get from that, and then we always have the HIPAA compliant issue, but but I'm just thinking that this, I mean, if it's already being used and successfully integrated into this program, again, bringing these resources and seeing how can we standardize this and see if it would work across other venues within this, building the continuum. And then, I mean, I think we're currently working to build a data dashboard for the emergency crisis services, and just seeing how this could be yet another piece that could be integrated would be wonderful.
Yes, and I think it would just involve talking with the pocket vendors. I know their CEO, Louise. I mean, they could present. We just need to connect with them. So everyone will have a better idea of what's it involve and how it can be integrated.
Yeah, that would be wonderful. Would you be willing to make that contact, or?
Sure.
Okay, that would be great. Is that okay, Kim? Okay.
Absolutely. This sounds great.
Yeah, that
Do
would
you know
be
how
wonderful.
long this program has been available?
We actually have been working with them here in the Department of Corrections for the last 2 years, and setting up infrastructure training here. So we mainly have people who are on home monitoring, are connected with it and utilizing it, as well as people receiving reentry services, perhaps in reentry court. But we're trying to expand that more now that all the detainees in the jail have tablets. So next step, at least for us here in inmate services, is to work with Securus to try to get the app and Pocket on the tablets. Then we can do a lot more things, and we're also trying to get other things on the tablets, which internally we've had workforce development videos that we made internally. We put those on tablets because all our detainees could benefit from workforce development, how to fill out applications, how to develop a resume. So all we're moving on to tablet, so everyone have access to that. So there's a lot of innovation that we're in the process of doing, but the Pocket app is, I think, a wonderful way to have all of us on the call and our services brought together to individuals, and with a touch of a button or app on their phone, just to have access to all of our services. So.
No, that's wonderful. I'm looking forward to hearing more about it.
Sure.
Because I think one of the things that we really, and then I'll go back to like the Maryland Consortium, they, and Kim and I and the rest of the team had talked about this, is like, they didn't want to start a hub or anything, but we need a place to be able to collect data, right? So we know what's happening, and if there's already an app being used and we can get the information, that would be wonderful, because then it helps us strategically go forward and plan, our next steps or where are our gaps. So this is wonderful. I didn't realize it even existed. And the fact that you're using it already successfully is wonderful.
I just wanted to point out, and I see Denise Dunbar's here on the child side. We also have an app called Mindula that monitors kids, and it actually sends them text messages on a daily basis and to see if they're okay. So it has a remote patient monitoring feature too, so it checks on people just to find out if they're okay. And I know Denise I believe, Denise, you still run that program, right?
Yeah, we still work with, it's actually associated with a suicide prevention program that Mindula runs for us. And it's a youth suicide prevention program that serve young people 12 to 21 who are at risk of suicide or have had a recent attempt or some kind of suicidal ideation, suicidal gesture, have been hospitalized and recently discharged from the hospital and could benefit from that ongoing support post-discharge. So it's Mindula Health is the name of the organization. And yes, as a part of their suicide prevention program, they do utilize an app that students or young people and their parents or guardian or whoever they designate as a proxy to support them during the program also have access to it.
Yeah, and thank you for bringing that up. We also use Mindula for the adult section for the, the behavioral health grant that we're working on. But this might be a perfect venue to talk about, like with Mindula. I'm not quite sure, Denise, about the duration, but with the adult app, they get 32 days. And then they're sort of like, this would be a perfect segue into like, we use one app that is like for 30 some days or 60 days and then it ends. Like, how do we then connect them maybe to the Pocket app? And can that be done? Again, it's taking them from a very intense program with an app to then like a more continuum and continuity, and then making sure there's maybe not that intensive contact, but there's still these touch points to move them along so that there's not the relapse. So this would be I love this just brainstorming and pulling all these things together is exactly what we wanted to do, because you guys are out there using systems and they're all, good. And then how do we work synergistically together to connect them that builds this continuum, just from us all talking together, bringing down the silos and helping us understand what's there and what are the capabilities of the apps that we're using. So thank you for sharing that as well.
There's also one called Prosper. I think it's newer, but it's a local person. His name is Eric Sullivan, and it's called Prosper. And I think that one focuses on young adults. It's called Prosper Wellness App, and it's aimed at engaging youth and young adults. So if we're, exploring those, that's something we can just add to the list as well.
Okay. Kim, are you able to put that? Are you okay?
Yes.
Sorry.
We're also getting a pretty good recording, so we'll
Oh, okay.
make sure to go back and get all the names of everything.
Awesome.
Yeah, thank you very much. So do we want to go? So what do we want to go to the next slide?
So this again, working towards that goal and collaborating with state initiatives and legislation. So specifically that hub and spoke model. And again, trying to unite forces to break silos.
And with that one, I feel like it will tie in a lot with the first slide, but we'll of course be coordinating with the LBHA to see what route the county decides to take and how the coalition can support all of those efforts through promotion to our partners or just serving as maybe an advisory group to help the success of this effort in the county.
Any reactions or next steps folks think we should indicate for this objective 2?
The one thing I was thinking about, Taylor, and what might be helpful is, and I know this may bring on a whole lot, but I think when we're talking about this spokes in a wheel, really identifying, what does the Prince George's County wheel look like? Where are those spokes? How do we categorize them? Are they evenly dispersed around the wheel to support the infrastructure of that wheel? So I don't know. That was one thing that I thought maybe just really identifying how many, I'm going to call them spokes, meaning that's supporting this behavioral health continuum in a hub or in a wheel. So, as we're looking at a centralized data point for collection, where is it going out to? And I know there's so many different programs, we can categorize them by, groups of individuals, whether it's youth, teens, adults, those with behavioral health, those with behavioral health and chronic disease, those that have dual diagnosis, what services are available in the county for homelessness, those kinds of things. Then we could get a real visual picture of what does our hub and wheel look like with the spoke. So I didn't know what people's thoughts were about that. So we could visually see, on a picture, what do we have in Prince George's County? Or if anybody had any other thoughts about that.
Margaret, I mean, obviously I agree with everything. And I think everything for me comes back to vaccinations. That's where my brain goes. But this model feels familiar to that. So we have like our mass vaccination clinics where we know that process can meet the needs of a lot of the population, but that we also have specific populations that have slightly specific or different or special needs that we can either reach through a home vaccination project or an on-site mobile unit project. So I think that that's kind of the vision that I'm seeing, if that aligns with what you're seeing, where we have this network, but then we have special populations where we have special services that address their needs as well.
Right. Yep. And then where do we maybe have gaps in that continuum, that we need, that maybe need, I know sometimes like residential or, programs, that may be something we need, because once we start putting the pieces in, we can then start saying, oh, wait a minute, well, what about this group? And then it allows us again more strategically when we're asking for funding. And then also, like, how do we collectively help one another? Like, I'll just say, if we have these apps that can talk to each other, we do a centralized warehouse and we have a database and somebody managing it and helping with navigation, that would help all of us, and we can maybe utilize our staff that has 3 or 4 hats like most of us, to share in that administrative health, behavioral health concierge type environment once we know what we have, and then we can set up grant opportunities to fill those voids. So those are just some things I'm thinking of, from a infrastructure building to have, a community-wide network. And then we also talked about within the geographic areas within the county, they're very different. Some may have an overabundance of resources and then others do not. So we can slice and dice it that way too, looking at the geographic locations. As to, we look at them like food deserts. Well, there's sometimes behavioral health specialist deserts or primary care desert, I mean, so there's, it just gives us another way to look at it and visualize where do we need to add services, and then how do we work together to support and unite each other to be stronger together.
And to add to Margaret's point of identifying the gaps that we might have, I think an important step here is to draw on the voice of lived experience and hold focus groups or opportunities to connect with individuals who can tell us from a firsthand experience where those gaps may be that we haven't put into the continuum yet, or that we need to bolster, that may be a bigger gap than we initially mapped out.
Yeah, I think that along with what Nina was saying is that we're working with state and federal governing bodies or regulatory bodies to explain to them the gaps and to lay out to them the barriers that we face, because I think a lot of times they're not aware, and once we can bring that to their attention, we'll be surprised how much people in management of these agencies could reach across the aisle and start working with us. For example, I know we were having a hard time with the law wanting there's a number of major opioid interventions, methadone, buprenorphine, Vivitrol, that we need to provide in a jail. And especially with methadone, we don't have the infrastructure because it's very heavily regulated. And so if someone comes into the jail who's on methadone maintenance, it's hard to provide it. But it looks like DEA is working with us, Drug Enforcement Administration, and they're looking at providing a waiver for us to be able to provide methadone to say pregnant women who do better on methadone, and if they're on maintenance, DEA is looking at giving us a waiver to provide that to them in the jail so that they can continue to have their to get their treatment, medicated assisted treatment, but yet we don't have to have a methadone clinic in the jail to be able to provide that. So we're grateful to DEA for even looking at that opportunity, perhaps of a waiver for us under certain conditions. So that's an example. I would. So sometimes we need. It's important to reach out to our regulatory bodies and let them know the barriers and the gaps, and we'd be surprised how much they would really work with us and what we all come up with. So, so to bridge some of these gaps. So.
Yeah, and I think what's nice, and thank you for that, because again, each one of us are our boots on the ground, and we know where we're working, where those gaps are, and then bringing everybody together, finding out what would be the best way to help, fill those gaps. And sometimes it's even finding another partner that didn't know that was a problem, because, you don't know what you don't know until you don't know you don't know. So it's like, but then, I mean, I would have thought that would have been, since it's a county program, you would think that they would automatically allow that to happen. But, so I learned something new today. So thank you for that. But those are exactly, what I think we can do as a group to identify those and see how we can help facilitate that. And again, even like with the emergency crisis continuum that we're building through the HSCRC grant, Maryland doesn't have a lot of these rates and regs, and they don't have a system, but we're putting it together. And Prince George's County can be the model for the state, because I think I've seen so much collaboration, with everyone across the spectrum of care for whether you're a provider, a facility, a government agency, a hospital. We are all wanting to figure it out. So that's half the battle. And I have to really give kudos to everybody that, has been in this realm, that they're really wanting to collaborate and see how do we strengthen each other. So this is great. So
And
now we
just
have 9 minutes. So Taylor, sorry.
Oh, no worries at all. I just wanted to put this in front of folks. I know this was a significant portion of our conversation last meeting, specifically talking about the opportunity for a social marketing campaign to address the stigma and discrimination associated with mental health and substance use. And so the idea here would be, before we would have that social marketing campaign, to be able to do a little bit of that research, to develop a white paper defining current resources and best practices around harm reduction, and be able to have all of that information to then go into this social marketing campaign.
And I just wanted to add, there are 3 regional behavioral health collaboratives in the state of Maryland, and we usually meet. And I know the regional partner in Baltimore, it's Baltimore City, and Hartford, I think it's Hartford County. They've done a lot of research on marketing research that I'm sure they will be happy to share with us, that, we can sort of start there and see how it applies, to our jurisdiction. But, they've done a lot of work around that already. And you know what I can do? Maybe we can ask them. I think they had a report, so we might be able to get a report, and then we can get it sent out to everybody here on the group. I'll check with them to see if we might be able to do that, because we're meeting with them right after this meeting.
And I know we have a few folks on the call related to goal number 2. So I just want to put this up for folks to see over and see if there are any thoughts anyone would like to come off of mute or put in the chat in our last few minutes together. This goal is specifically related to high-risk individuals and their social networks. So discussing mental health crises don't typically just influence that individual. It's going to influence those around them. It's going to take action of those around them as well as the individual. So seeing how the behavioral health advisory group can support both the individual as well as those social networks, and just meeting the needs of those folks. And we know that this group has a lot of expertise working across different populations. So wanted to make sure here that we had a goal that was specifically representative of that. And you can see here, we called out a few folks.
This is Larry Up. I just wanted to mention, kids with autism as a high-risk group, and people might say, why is that? And it's particularly because if they go into the emergency room, there's I think it's 3 or 6 beds that can accommodate them in the entire state of Maryland. And when Shepherd Pratt kind of looked into the needs for kids with autism in Prince George's County, it is kind of like a missing spoke that a lot of people aren't aware of until you kind of enter that issue with kids with autism.
I'll add on this specific goal that Mike Williams, who I know is here, sorry I called you out, in our PowerPoint, is doing a lot of work with the Returning Citizens Affairs Division, specifically on behavioral health services for justice-involved individuals. And we've talked about broadening this to the families of high-risk individuals, because there are so many focus points on the individuals themselves that we want to think again with a really global view of how we're supporting the full network of this individual, especially with resources dedicated in Mike's group, for instance. I know Elizabeth had to drop off the call, but in her portfolio in Department of Corrections, and then the Bridge Center, which is within the health department, and Dr. Wiggum is also on the call and leads the Bridge Center. So I've called them out and to talk about their work, but also to consider a global approach within this group.
Absolutely. Thanks, Nina, for calling me out. Appreciate you. But I think the Mr. Bairstow also mentioned the work that the Department of Corrections is doing. And what our division is really trying to do is to bring all of these resources together and to build the collaborations and partnerships. So we've partnered with the Department of Corrections on the Pocket app. We've been involved in that for, I guess, over the last several months. I mean, we want to continue to build partnerships so that we make sure that the men and women who are coming home from our state facilities as well as our county facility have the best chance of success in terms of reintegrating back into the community. And so anything that we can do to support, we are here to do that.
Mike, and thank you for that. You know, and again, we were talking about how you are integrating all the services for the reentry person, but then, you know, how do we then build that larger support for the family members, you know? And so I think, again, showing the coordination between you know, the jails, and then coming out, and then now, you know, we're getting further and further away into the community, but then once removed from you know, the re-entering person, how do we support their extended family? And then once that re-entry person phases out of your program, then we bring them all together and make sure that they have the support they need to move along that continuum. So this is a perfect example. So thank you for adding that. I was hoping that you would be able to show how already, you know, we're building these connections. And I think we can continue to strengthen them and build them and make them larger in an organized way. And then that's the beauty behind technology now. We don't have to go through like a phone book or you know, we can just, you know, Google or we can have it in our own app, that we can make sure that we make the warm handoffs, that connection, so that nobody drops off and is lost between programs.
Margaret, one of the things that we've talked about consistently is the whole notion of family reunification. And that involves work with the returning citizen as well as the family members who are still outside in the community. I just had a meeting a few weeks ago. Someone reached out to the county executive's office about supporting children in the school system of incarcerated parents. And so that is definitely on our radar. We haven't done anything in that area yet, but it's definitely something we want to look at, and are more than willing to roll our sleeves up and chip in where we can. Sorry, Dr. Wiggum. I saw you trying to turn in.
No problem. I was just going to kind of piggyback on what Mike was saying, and that we have such a strong collaboration with with ARCAD as well as with the DOC, and the Bridge Center is kind of like that middle ground where the work gets done. And we have clinical case management managers who work with returning citizens to assess their needs and their risk for recidivism, to incorporate family as a part of their process. We So we were also working, and we had talked about this. Mike and I had some conversations because we did have an organization through now I can't think of Shepherd Pratt that has a program that's designed for working with with children of incarcerated parents, and we're trying to make that part of the work that we do as well. We have peer recovery specialists that have that unique ability to relate one-on-one with the returning citizens. So we've got a lot in the works. We're trying to perfect it, because there are those individuals that do drop through the cracks, and we don't want that happening. But I think in our relationships, and I'm talking about problem-solving courts and the DOC, RCAD, we are really getting better each day at making sure that doesn't happen, and making sure that we effectively provide the services that our returning citizens need, as well as we're incorporating community partners to provide services. And so I think that we definitely have a good product. We just, there's tweaking that has to be done, but we're doing it.
That's wonderful, so and that's as we keep working together and adding more and more resources, hopefully we can strengthen that program even more. So thank you so much for what you guys are doing. But this is exactly when everybody comes together and sees how we can bring our strengths together and then find out where we need more services, or how do we shift to support where that is needed. So thank you very much for sharing that. Taylor, I don't know if you, was there anything else that we needed to add at this point? And
anything else for the group? We're just going to open it up for some time for community announcements. I know we have a few slides if anyone has anything else to add to this goal number 2 or any of the previous goals. All right, so just quickly getting into some community announcements. A lot of opportunities going on right now. So this is an opportunity that was sent out last week via email, but just wanted to uplift it again. This is a summer training series that is being offered by NACCHO. Here is the link for more information. It sounds like a really great opportunity to learn more about advancing health equity and drug overdose response. And they have 2 cohorts. One has just started and one will start later in the summer in August if folks are available to complete this training. And again, here is the link to visit that website to see more and to register. Regarding SAMHSA has put out a request for public feedback regarding their harm reduction framework. So we have put the guide here. This link here will take you to the guide that you can review and offer any feedback to this. This is also something that we wanted to put on folks' radar. So here for Medicaid eligibility. So again, if folks are enrolled in Medicaid, they must reapply. And so this form here has just some more information on that. Not sure, Kim, if you have anything to add here.
Nothing to add, just continuing to promote that this is happening.
Excellent. And then here with the Community Health Workers Hub, so just putting out information that it sounds like there's a new telehealth opportunity that's expanding with CHW. So just something to put on folks' radar to share with the community. All right. And any other community announcements from folks? All right. I see Amanda's hand.
Hello, how you doing? Can you hear me okay?
Yes, we can hear you.
I do apologize. My name is Amanda Lowe. I am the Assistant Executive Director at Empowering Minds Resource Center. So I just wanted to share with everyone that we are a behavioral health agency. We're in 5 different locations, but we are in Prince George's County as well. We currently offer targeted case management for adults in that location. So we do work with the reentry, whether it's from the correction facility or if they're doing reentry from a hospitalization facility as well. But we just wanted to talk about some of the community events that we have coming up, and I can definitely circulate flyers over to everyone. But we work closely with Prince George's Housing, so we will be in a few of their public developments the remainder of this month and going into August as well. Just giving back to the community, non-perishable food items, providing them with resources, whether it is in a need of our mental health services that they need to discuss, anything that they're in need of, we will be there to give them that information. We also do our annual back to school event that is on August the 19th. That is in our Baltimore location, Baltimore City at Mondawmin Mall from 1 p.m. to 4 p.m. But we will also have book bags to give away to the Prince George's County communities as well. So we will, after that date, we will go down there. We will have flyers out where we are able to disseminate those bags to the children in those public communities. So if you know anyone or they're in need of anything, I will put our website in the chat so everyone can have that. And it gives you a full of our services that are offered. But just if you can just share that information with any of your clients or any partnerships that you currently have, it would be greatly appreciated. Thank you.
Thanks, Amanda. Any other community announcements? Kelly?
Hi, Kelly with Clarent. We are the quality improvement organization funded by the Centers for Medicare and Medicaid Services for the state of Maryland, Delaware, and DC. I put several things in chat related to stigma. Some of them provide CMEs. One of them is exceptionally well done videos done by a physician. So if you have an interest, you could send those out to your group and let them each take turns looking at what they want to look at. And then we have a webinar coming up on August the 17th. I can send a flyer to someone to share. I'm not sure who to send it to, on opioids and misuse. We have 3 different organizations, community-based organizations, talking about what their initiatives are. One of them would be Calvert Health, and talking about medication for opioid use disorders in their peer counseling initiative. We have someone from Ohio speaking about Nalox boxes that they're placing in public facilities. And then we have an organization out of the state of Maine. So if you have an interest, just let me know who I need to send that to. Is that the email I'm getting in the chat that I see right now?
Yes, I'm typing my email for folks to send any flyers or any relevant event information to, and I will be sure to send that out with notes and send that to the group. Anything else?
Oh, sorry, Taylor. I'll just flag that Prince George is proud is holding an event on Saturday, July 29th at the Sports and Learning Complex. The health department will have representation from a number of our locations, including Bridge Center and Adolescent Clubhouse. And so I will share the flyer with you to distribute.
Great. I do have one last question. Do you all have a representative from the Opioid Response Network from District, I think it's District 3, which is serviced out of DC, that covers Maryland and Delaware and I believe Virginia? Do you guys have a representative on this group from there? Opioid Response Network, ORN?
I am not completely sure, but I will go through the registrants and I will also ask him. She had to go start a new meeting, but I will ask her.
Okay. When I email you this flyer, I will email you my contact for the ORN in this district.
Excellent. Thank you so much. All right. Any other community announcements? All right, well, I will be in contact with meeting notes. Everyone will have access to these slides as well as the meeting recording. But thank you all so much for attending and participating today. Just as a reminder, the August meeting will be August 16th from 2 to 3 p.m. And we just wanted to put this on everyone's radar with vacations and everything coming up. The Prince George's Health Action Coalition meeting will be on September 12th, Tuesday, September 12th, from 6 to 7:30 p.m. And this will be virtual this time. So we will be sure to send out invites to that event, but just again, wanted to put that on folks' agenda. All right, well, please feel free to let us know if you guys need anything else in the meantime. Otherwise, thank you again so much for attending today, and we will see you next month.
Take
Thanks,
care.
everyone.
Bye-bye.
Everyone.
Bye.
Bye-bye.
Be well, everyone.
Bye. Thank you so much.